All right. Thank you so much. Good afternoon, everyone. Let me start by introducing myself again. My name is Chiamaka Obina, and it's a pleasure to have everyone in today's NCKECO section. Today, we'll be looking at a very important topic. Yes, HAI surveillance, implementation, challenges, and a way forward. And as we all are aware, hospital-acquired infections remain one of the most pressing challenges in our healthcare delivery, impacting patient safety, prolonging hospital stays, and also increasing healthcare costs. And I would say that despite progress in infection prevention and control, implementation gaps and system-wide challenges continue to hinder sustainable improvements in many settings. And so, to share insights on this very important topic, we have our subject matter expert, Dr. Olufunmilayo. I'm going to go ahead to introduce her. She is a senior lecturer at the Department of Medical Microbiology and Parasitology, College of Medicine, University of Ibadan, and a consultant clinical microbiologist to the University College Hospital, Ibadan, Nigeria. She studied medicine at the University of Ibadan, thereafter specialized in medical microbiology at the University College Hospital, Ibadan, obtaining the fellowship of the Nigerian Postgraduate Medical College in Pathology. She holds Master of Science degree in epidemiology from the University of Ibadan and a diploma in medical mycology from Pasteur Institute, Paris, France. She is interested in epidemiology of infectious diseases, especially in hospitalized individuals. Her research and clinical activities have focused on fungal infections, control of infection, and antimicrobial resistance. As an infection control practitioner, Dr. Makajula has been a key member of University College Hospital Infection Control Program for over 5 years. She has garnered experience and expertise from her activities in UCH Infection Control Program, a comprehensive IPC program established over 40 years ago, making it one of the earliest in Nigeria. Domiciled in the Department of Medical Microbiology and Parasitology, the program incorporates routine surveillance of healthcare-associated infections as a major activity to ensure patient safety. She is a coordinator at the annual training course on surveillance, prevention, and control of HAIs organized by UCH Infection Control Program. She currently represents the HOD as the UCH IPC focal person. She continues to build her capacity as an IPC practitioner and is currently undergoing the CCAPS Diploma in Infection Prevention and Control Program. She is also a member of the Nigerian Society for Infection Control. Please, let's welcome Dr. Funmi, such a very robust portfolio. Let's welcome her with our best emoji on the chat box. Dr. Funmi, you have the floor. Please, let's do well to take note of our questions. We're going to take that at the end of the sections, your comments, questions, and contribution. You can go ahead, Ma. Let me stop sharing my screen so that you can share yours. Thank you so much and welcome once again.
Thank you very much for the kind introduction. Good afternoon, everyone. Thank you very much for joining this meeting.
Welcome, Ma. Thank you so much.
Good afternoon, Ma. Oh, I just realized my screen has been black. Good afternoon, everyone. It's nice to see you all. I want to thank the Nigerian Society for Infection Control for this opportunity to present a topic I'm really very interested in, HAI surveillance. So, okay, I think my screen is on already. Please confirm that you can see my screen.
The slide is not projected yet. But
okay, thank you very much. So I'll be talking about HAI surveillance, implementation strategies, and way forward. So I've taken my video off so that I can have enough bandwidth and there's no interruption. Because not something so easy to do on a regular basis, so we need to keep reminding ourselves. And one way is to keep on asking yourself this kind of questions as I've posed in this introduction. So as the IPC focal person in your facility or IPC practitioner, can you tell whether the annual prevalence of HAI or this particular HAI, maybe bloodstream infection, is increasing or reducing in your facility? If there are cases of wound infection, probably a surgical site wound infection with MRSA, can you tell if these infections are related? Which is something I would tell you that is probably an outbreak going on in that particular ward. So can you tell? And the last question is, somebody, an NGO or a donor wants to give funds and says, oh, we want to donate funds to your most prevalent HAI in your facility, which would you recommend? So all these require us to have carried out surveillance for us to have data to answer that question. So the outline I'll be following for this presentation, we have an overview of which introduces us. We're actually doing the role of surveillance. How is surveillance implemented, which is the bulk of the presentation. Then what are the challenges that can occur with surveillance implementation and the way forward in terms of recommendations for improving our HAI surveillance activities. So HAI is an infection which occurs in the process of care in a hospital or other healthcare facility which was not present or incubating at the time of admission. And sometimes it appears after discharge for this. Outside the regular hospital setting. So you may have maybe a dialysis center that is not an actual healthcare institution or an old people's home where they provide healthcare. Types of HAIs, any organ can be affected, any system, any part of the body can be affected by HAI, but these are the common ones. So surgical site infections, so post-surgery infections, pneumonia, which could be health-associated pneumonia in the lungs, or where there's devices that are included. So if you have a patient with ventilator, they can have ventilator-associated pneumonia. UTI, particularly when the patient has device, so catheter-associated UTI is a common HAI. And then bloodstream infections, particularly central line. So you can see that many of them are due to procedures or activities in the workplace that introduce pathogens. Impacts of HAIs, mainly that they complicate healthcare generally. So there's longer hospital stay, patients spend more, so higher healthcare expenses, patients get ill, so there's higher morbidity. Sometimes they have complications that do not actually resolve even after the patient is well. Also increased mortality. And of late, we are really concerned about HAIs because it contributes a lot to the spread of antimicrobial resistance, of course, which are difficult to treat infections because of limited antimicrobial options. Burden of HAIs, there's no place that doesn't have HAI. So you can see that the charts from the WHO that shows the poor prevalence of HAI. Even in the USA, you can see that they have about 3% HAI. But lower and middle income countries have an unusually higher burden of HAI. So you can see African region there, almost 9 times. That's 27% for African region. Mainly because they have limited resources in their healthcare facilities and they have inadequate infection prevention and control practices. So what we are trying to do is to improve infection prevention and control so that we can reduce HAIs. And so the WHO has these core components for effective IPC. Many of us are familiar with these core components. And you can see that surveillance is core component 4. So surveillance is very important as a means for controlling infections within healthcare facilities. How do we define surveillance? You can see many different definitions if you check online. But what is very important is that in that definition, you will see that it's a continuous process, it's a systematic process. You collect data, you analyze, you interpret, you evaluate, you also disseminate. So HAI surveillance is a formal documented system and procedures for identifying, monitoring, evaluating, and reporting the incidence of HAI or related events. So we say HAI or related event because not only infections that we monitor in HAI surveillance, even though infection is the most common item that we monitor, but we can monitor other things, hand hygiene compliance, how healthcare workers take up vaccination programs. So those are related to HAI. So we can also do surveillance for them. So it involves systematic collection, collation, analysis, interpretation, and timely dissemination of information related to HAIs, and doing so to provide information that will guide appropriate action. HAI is very critical. Historically, many of us would be familiar with this phase. If you remember the history of infection control. So Semmelweis was an Hungarian doctor who actually did what we classically call surveillance because he noticed infections were taking place in obstetric ward, collected data and noted that this data shows that is when doctors and medical students take care of the patient that gets infected. And then he went on to investigate. So he didn't stop at data collection. He investigated so that he can give them recommendation. And from his investigation, he noticed that, okay, they go for autopsy and go straight to the obstetric ward. And so from that, they acquired infectious agents that were infecting patients, unlike midwives that were not going to the autopsy room. And based on that, he recommended intervention of hand washing, and that was noted to reduce the infection. So it's important to do surveillance in the proper way so that it can generate useful results. So importance of HAI, patient safety. So it improves patient safety so they don't stay in hospital for long and they don't have increased morbidity and mortality. It helps to optimize resources because you can't really have unlimited funds. So surveillance will help you to determine where to allocate your resources, and it's also a way to improve the quality of care that we are providing in our facilities. How do we use surveillance data to do all these things I mentioned earlier? So you can use the data that you generate to establish the baseline infection rates. So of course, if you have the baseline, then you can know whether it's increasing or reducing so that you can institute measures. You use this to monitor the trends. So this particular infection was a trend in that particular infection or a particular organism. It helps to detect outbreaks because by the time you are monitoring, if you see that, okay, we used to have only one infection in this world, now they have 5 and they are related, then you think of an outbreak. It helps to identify important pathogens to target with interventions. And it's also to identify areas in the facility where you can actually focus on intervening because, as I mentioned, resources are limited. You also want to use that data to monitor the effectiveness of whatever control measure you have instituted. I'm going to focus on HAI surveillance at facility level. I know that we can do it nationally or at the facility level, but I'll be looking at HAI surveillance at the facility level. And it's recommended that every IPC program, even though many programs do not incorporate HAI surveillance, but it's recommended that we have HAI surveillance in our facilities, no matter how small. And implementation should not be arbitrary, it should be based on national recommendations. So you have national recommendations by the NCDC, so you use that as your baseline, and then customize according to your available resources, because you may not be able to do everything in that recommendation or the operating procedure, but you can customize to your facility. And implementation, of course, and customization will depend on what you have at your disposal. What's the size of a facility? How many patients? What are the types of infections that you see? What kind of patients do you have there? What resources are available? So that will help you to determine what you can do, but at least make sure you're doing something. So the components of HI surveillance, what are the things that are necessary for you to say you're doing a HI surveillance? You need to have a case definition. So what health problem are you defining? So you have to, or maybe it's a single one, but you need to define the health problem that you need to survey as precisely as possible. Then you need to collect your data using standard definitions so that you are collecting valid, relevant, and comparable data that you can use for implementation of measures. Then you would collect that data. So it's not just for you to collect the information. You need to collate it, analyze it, and interpret it in a manner that is useful for intervention. And you need to give a feedback to those who need that information for improving patient care. And your feedback should include recommendations for what they can do. So once you are doing all this, then at least you're able to achieve a wholesome HI surveillance program. So now I'll talk in details about how you can practically go on with HI surveillance in your facility. What are the requirements for implementing effective HI? So you need regulations and guidelines, you need human resources, laboratory capacity, you need to determine the type or scope of your surveillance, you need to determine the surveillance methods, the data management processes, and procedures. Concerning regulations and guidelines, you need clear regulations, as I mentioned earlier, to guide your data collection, reporting, and analysis. And this is a cover page of the NCDC Infection Control Manual, which all of us should have. It's readily available online, so you can download it to guide your facility in IPC measures. And then there are aspects that have HI surveillance in some of the chapters there, so that you can have standard definition for different HIs. There's also the WHO document in 2024 that talks about some surveillance of HI that you can download and work with. Human resources, you need to know what human resources you have. Ideally, you should have identified and dedicated personnel for data collection. So your IPC program should have dedicated personnel for data collection. And it should be an adequate number. The recommended number is 1 infection control practitioner per 250 beds, a dedicated one. But of course, we understand that many facilities may not be able to have dedicated personnel. Many people juggle multiple duties or obligations. They should be trained. So your resources, your IPC personnel should be a trained person who is able to identify infections and opportunities for infection transmission. So they can identify risk apart from the infections, and they can generate some reliable data. Laboratory capacity is very important because you need to be able to confirm those infections. So you need accurate diagnosis. And then because of the emerging upsurge in antimicrobial resistance, you also need a facility that can identify antimicrobial resistance. And then if your method of data collection or surveillance is lab-based, then you need a good lab. But of course, it varies in complexity or in of the lab. You may have very simple labs where all they have is a microscope, or you may have large laboratories of research capacity with automation, but you should have a strong laboratory backing. Scope of surveillance, you need to determine, are you doing comprehensive surveillance where you are monitoring all infections in your facility, which is quite resource intensive because you want to check all infections, even though at the end you may still categorize them, but you want to look for all. Or are you doing targeted surveillance where you target, either you select the common HAIs, that means you have done some background analysis to know which are the common HAIs in facility. Then you do a targeted surveillance either of central line associated bloodstream infection or SSI or CAUTI. You pick if you don't have enough resources to do the comprehensive or total one. You may also pick epidemiologically significant organisms to monitor. So you can choose MRSA, vancomycin-resistant enterococcus, organisms that can cause some problems in the health setting, like clostridial difficile infection, where you can have outbreaks if you do not monitor and control them, or respiratory viruses. You may also decide to pick a single unit or patient population in your facility, particularly when you know these are the patients at high risk of infection. So you can target just the ICU or just the neonatal unit or just the obstetric ward in your facilities for you to, particularly if you are just starting and you're not able to do a comprehensive one, then you can do a targeted surveillance. Or like I mentioned earlier, if you have donor and it's a targeted surveillance activity, then you can pick any of them. So methods of HAI surveillance now, so that could be active or passive, prospective or retrospective, lab-based or ward-based. So I will talk about each of these in subsequent slides. So your method could be an active surveillance or passive. In active, you actually have trained IPC personnel who are dedicated, who look vigorously for HAIs, and they generate information by various sources so they can get to the lab, to the clinic, by talking to healthcare workers. So they generate information actively. Whereas in passive surveillance is those who do not have primary surveillance role, but they may just identify or suspect maybe an infection or an outbreak, and then they just passively mention it. So, okay, we notice that on our ward, patients are having a lot of UTI. Can you investigate it? So that's a kind of passive surveillance. And with my facility, there's a combination of both. So we do active surveillance, but sometimes some may get missed, and then it's those on the ward or maybe the doctors managing the patients that point our attention to, oh, this is probably an outbreak. For example, there was a patient was admitted in a particular unit, apparently acquired infection before moving to another ward. So of course, when you look at lab data, you see one ward and the other infection, even though they're identical, another ward. So you may not be able to tally them. But the doctors mentioned that this patient was already in a ward that had those infections before moving to that. So that way, you can combine both active and passive and get some useful information. You can also have prospective data collection or retrospective. In prospective, it's real time. What we do is prospective in my facility. So every day you check the laboratory records for evidence of infection. For retrospective data, if you do not have dedicated personnel, then you can do a retrospective, maybe at the end of the month or at the end of the week. You just collate all the data and then look for infections and follow up. Of course, that is not the data that you generate from there, be as the utility may be lower compared to what you have with prospective. For surveillance, it could be ward-based or laboratory-based. So in ward-based, you're checking, so ward-based could also be active. You are reviewing patients' records regularly to look for infections, risk factors, and outcomes. So you're monitoring infections, checking the patient's charts. It's simple, it is cost-effective. However, it's subjective because you don't have confirmed infections. And so it's the person's judgment of whether there's an infection or not that you rely on. Whereas for laboratory-based surveillance, you use laboratory data where you have confirmed infections, and then you follow up those infections on the ward. So you check patient laboratory data, you see a patient in male surgical ward has an infection, then you go to that ward to continue the surveillance activity. So you're identifying the patient, looking around for the risk. My showing unstable. So thank you so much. So you can also, that way you get accurate data, you have specific pathogens, you can monitor antimicrobial resistance. However, the drawback for this is that you are dependent on data generated by those who send requests to the laboratory. So it has a lower sensitivity. Many infections will be missed if the clinician manager does not send a request for investigations. And also sometimes patients have clinical infection, has every evidence, but then there's no growth on culture. So and since you are using results generated, you may miss out many infections. What do you use to collect your data? Your data collection instruments could be manual or electronic, depending on the resources that you have. This is not very clear, but this is a screenshot of what we use for data collection. So we start with a manual for collecting the data and then move on to entering it on the computer. So we start from manual and then electronic to complete the data collection and analyze the data. So if you can see this one, for example, you see that it starts with data from the lab. The organism that grows is there. So if you now go to the ward and you observe the patient was admitted yesterday, and then this sample was collected that same day, it yielded particular organism, then you disregard. So you can see the comment there that patient was admitted with the infection, and so that does not qualify as HAI, even though it's an infection recorded in the hospital setting. So this is electronic form now, where we now enter the data after the manual collection on forms, and we use this for analysis. So you can see it's been analyzed, even though we do a comprehensive HAI surveillance, but you can see that the analysis is by ward, services, by units, and by the type of infection, so that you can get your results by infection, by ward, by patient category. You need to analyze that data. So it's important that you analyze the data and disseminate the information. And it's very important to know that surveillance is not complete until the results are disseminated to those who can use it to prevent and control infections. Because oftentimes many places collect this data, but they just lock it up either in a drawer or in a computer where there's data, but it's not useful to those who can use it. What do you report when you're doing the analysis and reporting? You want to report outcome measures. For example, the lecture is focused mainly on infection rates, so you can actually determine HAI rates or specific infection rates or specific pathogen rates or types of injuries. Those are called outcome measures. And sometimes you can do your surveillance to measure processes, so process measures. Hand hygiene compliance, for example, how well are people complying to hand hygiene? I think that was the last month's ECHO lecture 2 months ago, where we had something on hand hygiene compliance monitoring, where you have forms that you can use to audit hand hygiene. So that's a process measure. Or you can monitor adherence to care bundles. So ventilation pneumonia care bundle, UCI bundle. So you can use the reporting to measure that and give feedback. So what your report usually is as rates, and then when you want to present it, you can show it as trends or impacts. How do we calculate the rates? Our numerator, many times we have numerators because we know the number of HAIs, we know the number of outcomes during a particular period. But that number is not very useful if we do not have a denominator. So our denominator will now be the total number of population at risk at the same period. So if your numerator is number of infection in January, then your denominator has to be number of patients at risk of infection in January. And they have to be at risk. So you divide your numerator by denominator. Denominator is very important because you want to get a rate. And our denominator is those at risk. So for example, the admission number or number of patients on urinary catheter then tells you those who have infection over the number on catheter. So you have to use that to generate your rate. So you have an overall rate, number of HIs, over the number of admitted or discharged patients on that particular unit. The specific rate is by those at risk. So UTI, catheter UTI rates cannot be for all those on the ward. It has to be only those who are on catheter. Rate by pathogen, so you can pick MRSA or Klebsiella pneumoniae. By service, what is the obstetrics infection rate, or by patient care care area, so neonatal units, special care units, surgeon-specific wound rates. That may cause some issues, but it's also carried out because you may want to see, okay, maybe a particular procedure or a person infection, as she said, whenever that person carries out surgery or whether a particular procedure is done. is not to attack anyone, but to help you to investigate the cause and so that you can institute control measures. It's always nice when you present your results or analysis in a way that is appealing to those who are not core healthcare providing personnel or who understand data analysis and such. But if you put a picture or a chart, everybody understands that. So it's good once you analyze your data to present it in a way that carries or that carries that passes information across. For example, this is HI trends in UI published by IGAIN 2011 that shows the trend in in UCH infections from a particular year, 2005 to 2009. So you can see it increases and then it drops. Of course, we need to understand that these are really gross underestimates because of our capacity for diagnosing or sending samples for investigations. So of course, this is an underestimate of 2.3, 2.7, thereabouts. Then you can also use such as pie charts just to show the distribution. So just by looking, you can see that this particular chart shows that ICU infections are the highest in prevalence compared to where you have, for example, East 2, which is a surgical ward, compared to another surgical ward, Northwest 1. So it gives you a quick look at the trends and infections and where you need to institute measures. So of course, looking at this, you want to focus on trying to control ICU infections. Challenges now, numerous challenges. They hinder the capacity to implement, sustain, and ensure the effectiveness of our IPC programs when we have all these challenges. What are they? This is a quick list of the challenges, and I'll look at them in a little more detail in subsequent slides. So lack of funding, very, very important. Many facilities do not think about IPC or HI surveillance. There's low commitment, so low resources. So lack of money, lack of manpower because we have limited numbers of staff. And so there are not enough staff to be dedicated to IPC or HI surveillance. Training may also be inadequate in some places. So limited training, inadequate training, limited laboratory capacity. So laboratory may or may not be available. And when they are available, they may not have enough equipment or consumables or expertise. So that would affect the ability to generate quality data. Then data collection challenges, incomplete or inconsistent, particularly if you don't have personnel. So they are collecting this month, next month, nobody is available to collect data. So it will be difficult for you to monitor. The paper-based system will be cumbersome. You need to print papers. It's after collecting on paper, you transfer to your computer. So it's quite challenging. Data analysis may not be accurate if you do not have a dedicated personnel who understands data analysis. You may just generate wrong conclusions when it's not properly analyzed. Incomplete reporting too will be an issue because you don't have enough data to report. Quality of the data as well. Incomplete medical records. So sometimes you find an infection, you go to check the patient's case files. You don't have enough information for you to have reached a conclusion. Inadequate training, so you may not have trained personnel that can actually extract such information even when they are available. And then under-reporting of HI cases I've mentioned earlier, it's a major problem because you don't have enough laboratory capacity to see this person had an infection because they are not testing. So all that will make one have an erroneous conclusion. You are saying because only one test was done in that particular unit in the month that has an infection, you say 1 out of 50 patients, 2% infection rate, whereas maybe 10 of them had, but they were not tested. Another problem is lack of standardization in surveillance methods. So it needs to be standardized in what you are doing in your facility. If you are doing active surveillance, you don't do active today and then you say there's no personnel and do passive only for another few months and then active again. or you decide today we are doing charts, and then next time you choose laboratory. So if you do not have methods being standardized, then it's difficult for you to analyze whatever results you're generating. There's also a problem of standardizing definitions of HAI. So if this month somebody says one definition of ventilator anemia is this particular one, next month they use another definition, you will end up having results that are not comparable because we are using standards or definitions that are different. It's also difficult to compare if UCH is using one definition for surgical site infection and then Lautech beside us is using a different one. When you have results, you really can't compare them. And then difficulty or inconsistency in interpreting data, you can actually look at it and interpret it wrongly. So those are some of the challenges. A major challenge is also utility of data being generated. If you have your data and you do not send the results in 3, 6, 7 months, then it's not very useful because if they had seen it much earlier, they may have noticed an outbreak that they could have either controlled earlier on and reduced the morbidity and mortality or institute measures, but you're sending it maybe 1 year after. So it's just, okay, we have data, but it's not useful for patient care. So generally, all this impacts on HAI surveillance, giving us inadequate data, incomplete reporting, difficulty comparing results, difficulty establishing benchmarks nationally or internationally, erroneous conclusion, misallocation of resources, and ineffective HAI prevention strategies because of those challenges. So what's the way forward? What are the recommendations for improving HAI surveillance? So I'll talk about the items on this list. First, we need a commitment of the institutional leadership. You need your management to support IPC and HAI surveillance. So all IPC activities in general. Once they're able to support it, then you see that they are able to provide the resources that we need to have good IPC and HAI surveillance, particularly funding. So they should dedicate or commit to dedicated funds. So they should have a funding line for IPC and HAI surveillance. They should encourage involvement of stakeholders. So all the units that are involved is not only IPC. So you may have environmental units, pharmacy, so many other units involved in HAI surveillance activities. So they can encourage and facilitate that kind of work together. They also are able to support training once they have their commitment that they can send healthcare workers to have training in IPC and HAI surveillance. Capacity building is very important as a way forward. So human capacity and lab capacity. So human capacity, ensure adequate human resources for surveillance, invest in capacity to train workers on healthcare workers and IPC practitioners. So what is ongoing now, at least during my introduction, I mentioned that I'm undergoing the Diploma in Infection Control Program. That's the capacity development. I want to thank the MCDC and other partners who are involved in ensuring that the capacity of healthcare workers is built in IPC as IPC practitioners. The laboratory capacity enhancement, improve lab capacity, so provide them resources, equipment, consumables that can help them to do adequate and good quality surveillance activities for infectious diseases, HAIs, and AMR identification. It's very important to have timely communication and feedback within and among healthcare institutions. So if within my institution, we give a feedback to those who can control infections on the wards or in the clinics, they get to support our activities better because they know that what we are doing is important. So we should ensure that we have timely communication and feedback to clinicians and other healthcare workers who will use that feedback. Then we need to leverage technology. That's where the world is moving to. So we need to leverage on technology for improving surveillance. So you can, rather than using paper-based methods, you can use our mobile devices to collect data. And that way, if you are collecting data you can also easily send that data to units that will need it electronically. So you don't have to use paper and then have to write another memo to send the information across. You can take advantage of AI. AI is being used in every aspect of life now. So we can use AI for HAI data collection and analysis in particular. So it can help us to analyze our data. You don't have to do it manually. So once you get the data, you analyze it. It helps us identify patterns that show that, okay, there's an infection here or the trend in the infection. So we can do that as well. Um, Molecular epidemiology and genomics helps us to increase the accuracy of our HI surveillance, because if you are doing molecular testing, then you can generate more detailed genetic information about the organisms, and so you can see how related they are. So if, like the question I asked, if on the world you see that all the mRNA are actually related in terms of their genetic makeup, then you can know that, oh, they probably have a single source where it's been disseminated within the world, and look for that source and eradicate it. So genomics and molecular epidemiology helps in that. Then you can have integrated surveillance systems. So you can integrate your surveillance activities with other electronic health records in your facility. So that way you can easily get your patient's information. You can easily identify the risk factors because you have all the patient's information that you're not just looking for by yourself. They are already there on the system. And so you can identify risk factors and control measures. Then we can leverage on international collaborations and partnerships. So you can collaborate with organizations that help to strengthen HI surveillance, like the WHO and the Centers for Disease Control, the NCDC. You can also have partners in institution. My institution, there's some grants ongoing that the results they generate help us in our HI surveillance, which we will not be able to do without those grants ongoing within the facility. So they can help in HI surveillance actions. So these are my resources. And I want to thank you for your attention.
Thank you so much. Thank you so much, Dr. Olufumi Lola. Thank you so much. Really appreciate the time that you have shared with us and also your expertise. Please, can we appreciate her using our best emoji in the chat box? Let's have it. Thank you so much. We really appreciate. And then we'll quickly go through the chat to see if we have questions, comments, contributions. Okay, someone said, good day, everyone. Hoping to get an impactful section since HAI is a big burden on the world due to challenges beyond the healthcare workers. Okay, that's a comment. I think there was, I'm looking out for it. Okay, someone said IPC monitoring and evaluation is heavily dependent on managerial will. And yes, she mentioned that commitment from the management will really go a long way in helping us to surmount HIS in our healthcare facilities. And then someone said, which scoring system can be used to assess hand hygiene compliance? That's a question. Which scoring system?
I need to read all, or I should answer each one you ask.
Okay, let me see if we have more down. Let me check. Okay.
Okay, so while you're checking,
okay, you can go ahead, Ma. Go ahead.
Okay, so you said somebody asked which scoring system you
yes.
to. So there's a form, an ID observation form. It's actually readily available online, where you can assess how healthcare workers perform hand hygiene for each of the 5 moments. So you have indications and opportunities. And of course, it's an entirely different lecture by itself. I remember that Dr. Godswill
yes,
presented it last month or thereabout.
Yes.
So actually, the form is self-explanatory because it has keys and codes. So if you find it online, it can help you to. So based on that, because you know the number of opportunities, Then if that person does it 3 out of 5 times, then you know that, oh, this is 60% compliance. Or he does it 1 out of 5 times, then 20% compliance. That's it.
Okay, like you rightly said, we had a whole section on that. That was 2 months ago, Dr. Goswe Ogbonnaya. So you could, the person who is asking the question, you could go back to the recorded section which I shared with everyone via email or his slides too. Okay, so there's someone the comment they said, but how can we reduce HAIs when there is no IPC program in many healthcare facilities and surveillance system? That's a big problem.
Yes. So if you remember the WHO core components for IPC, it starts with IPC program, and even the IPC program surrounds the entire thing that you do. So you must start with having a program. No matter how small they are starting, start with a program, particularly a personnel who is trained, and then from there you can move on to other activities like training, education and training, HI surveillance, and others. But start with your having a program. And of course, that means that you need to do advocacy to your hospital management or your facility management to encourage them to commit to an IPC program. It's not something one person can do. You need the support of your facility.
Okay, so okay, so there's a question here. In your experience, what are the key components of an effective HAI surveillance system in resource limited settings? Resource limited settings.
Yes. So for resource limited settings, definitely you must have somebody. You may not have a dedicated person, but you have a person who is involved in IPC and HAI surveillance. So that person can do it on a part-time basis until you have a full-time person. The person needs training because you need to understand what you're doing. So it may be a self-directed learning. Luckily nowadays, there's so many things you can find online. It's not optimal, but you can get some information to help you. You start small. Pick a word, particularly maybe a word that you know that might be problematic, maybe ICU or surgical ward or neonatal ward. Start asking about infections in that place. You record. Do a follow-up. Advise them. Let them institute their measure. Record it. By the time you have a report, this month you send a report to your hospital management. Next month you send another report, particularly if your recommendations have led to improved outcomes. Next month you send a report. With time they start to show attention to your HI and IPC program and dedicate resources. There's always something you can do, no matter how small.
Okay, thank you so much for that beautiful response. Please, if we have more questions, let's have them in the chat box. Okay, so meanwhile, someone is saying, what challenges have you encountered with staff engagement and compliance during HAI data collection? Are there challenges with staff, getting involved, staff engagement and compliance?
For a surveillance data collection,
Yes, yes, yes.
okay, we use a lab-based surveillance, and because our facility, we've been on it for a long time, so everybody's aware. Once the infection has been detected in the lab, you go to the ward, you ask questions. We have link nurses who can facilitate your investigation on those wards. What you may have issues with is when you recommend measures and people may be slow in complying, or people may not be happy with your decision because sometimes you may say maybe a particular word cleaning and disinfection was not well carried out. That's why there's an outbreak. So you may need to do a more vigorous cleaning, or sometimes one of our recommendations sometimes is to completely shut down a particular unit if you have repeated infections. It may not go down well with some individuals, but generally the response is adequate.
Okay, thank you so much for the response, Ma. Okay, so one hand is up. Okay, go ahead, please, Dr. Oluwaseun. You can go ahead with your question.
Thank you, Dr. Makanjala, for the presentation. Okay, now the other time that someone mentioned a place with the low resource setting and minimum requirements that may be needed to run such program in such instances. I want to be sure. Now, in such instances, can we safely assume that as the current system of hospital facilities that we have in Nigeria at the moment, can we safely assume that we may not necessarily categorize them under low resource settings? What I'm trying to say is this: we were made to understand that minimum requirements for IPC in PHC settings, in secondary facility and tertiary facility, we were made to understand that in the PHC setting we may not necessarily.
Is it me? There's no audio anymore.
Can anybody hear me?
It is from his end.
It's from his end.
Okay.
Oh, I think he's no longer on the call. Okay, so while we wait for him to rejoin, I think he was trying to emphasize on in low income settings like okay, Nigeria, for example. So what are the minimal requirements? And I'm even seeing a question here in the chat. Someone say, what strategies can be shared for implementing HAI program in low resource setting? I think that's the same question coming up again. Strategies that can be shared for implementing HAI's program in low resource setting. We can't escape the fact that there are actually some facilities that may not have every requirement to have an effective HAI surveillance in their own setting. So what can they do differently?
That was what my response earlier. You may, of course, when you say low resource, the entire Nigeria, you can categorize Nigeria as a low resource setting, but within Nigeria, we have facilities that can do the full complement. We have maybe a PhD that may not be able to do much, but what you need to do is ensure that you have an ongoing activity. You collect your data in a systematic fashion, pick what you can do. Like I mentioned, if you don't have enough resources, you may not be able to do HAI surveillance in your entire facility, but you can do surveillance in a unit. You can pick a unit where you see that because the entire reason why you're doing your surveillance is to be able to control infections, improve patient safety. So you pick an area where your activity will be most felt. There's no point going to maybe a medical ward where they don't have infections. But usually in many places, there are surgical site infections, there are neonatal infections, I see. So pick one unit and start your activities there. That will not require too many or too much resources. You can start with patient records if you don't have a laboratory that is functioning. Definitely in the patient records, a clinician would have written maybe query lobar pneumonia or something. So at least you can use suspected infections as your case definition. That's why you should have a case definition in your facility for your surveillance activity. So if you define it based on clinical diagnosis, use that until you're able to have a lab that can help you with your sample processing and having a definitive diagnosis.
Okay.
Does that
Yes.
answer the question?
Yes, thank you so much, Ma. So, let's look at data use and feedback, because we all understand that it's one thing to, gather this data and another thing to use it to make informed decisions. So how can we ensure that this data collected through HAI surveillance are actually informed clinical practice and policy decisions, especially where they are needed?
Thank you. So that information you are getting must be analyzed. So if you have data collection forms, the information you get has to be analyzed. And analysis is about generating rates. So you cannot just collect numerator data in terms of how many people have infections, what type of infection they have. You must have a denominator, which is those who are at risk. And so that prevalence or that rate it generates is a problem. Now you need to identify why the problem is occurring. So that is one step further in terms of there's HAI 3% on this word. Why? If you know the reason, then you now make recommendations. So your reports, what you are presenting to the clinicians or your hospital management, is something that they can use. There's no point saying, oh, this word, you have 5% HAI. It's not useful information. They just hear. But if you say you have it because of poor infection control practices such as hand hygiene or sterilization and disinfection, this is what you need to do. And then they do it, they see a drop. Then you see that that intervention has worked. And then you can now move on to continue to do it on a regular basis to monitor. This is what we have done. Next month, if you do our surveillance activity and we see 3%, then we know that that 5 has dropped to 3, 3 will drop to 1. And so that means that our activity is working. But you need to give a feedback and it has to be timely. So a situation where you are generating data and submitting at the end of 1 year is not a useful data being generated. Of course, many of us are guilty of that, probably because of lack of resources. But if you want your information to be useful, it has to be timely, it has to be analyzed, it has to be presented in a way they understand. So there's no point using a lot of statistical jargons, I would say. But if you present a picture or a chart that shows even an illiterate can understand, oh, this is going up, this is going down, then it's useful.
Oh, that's great. That's great. Thank you so much, Ma. And that brings me to the next question, actually, not just for you, but open to every one of us in our facilities that are carrying out HII surveillance periodically and intervals. I don't know if there's anyone who wants to share success stories where their HII surveillance data has led to meaningful change in patient outcomes. Is there anyone who is open to share? Okay, so while we wait for people to, because I really want to hear from people, I really want to hear from, especially because we have so many people who are joining us from different facilities that cut across the 6 geopolitical zones. While I'm waiting for the response to that, I want to read a question here in the chat box that says, how reliable is, very important, very good question. How reliable is clinical diagnosis is the absence of laboratory confirmation? Most patients would reject lab tests when they know it is for surveillance purposes, especially when they pay out of pocket. Okay, this wasn't the question I was expecting, but let me read it again. The person said, how reliable is clinical diagnosis in the absence of laboratory confirmation? Most patients would reject lab tests when they know it's for surveillance purposes, especially when they pay out of pocket. So there are certain tests that will be done that there's need to do a laboratory like a confirmation. Yes, a confirmatory test. So who pays for that? And most patients will reject that lab test when they know it's just for surveillance purposes, especially when they have to pay out of pocket. Hello, Ma, are you there? I think it's network. Please, Ma, confirm that you can.
Yeah.
I guess it's the network. Are you able to hear me, Ma?
Well, you kept breaking up, so I was talking while your network was not available.
Oh, okay. Let me read the question again. The person said,
"Oh, I've responded to the question. I hope others heard."
Oh, okay.
Okay, I will repeat because you heard and you didn't hear. Maybe others too did not.
Okay.
So I said that our primary purpose for laboratory testing is not for surveillance. The test is to confirm the infection and to treat appropriately. But you can now use that data for surveillance activities. That is not the primary reason for telling a patient to go and do a test. And your first question answers the question. How reliable is clinical diagnosis? Because your reliability of your confirmation of your test is by doing a laboratory test or a medical test to confirm the infection. So that's why we prefer laboratory generated data, because lab tests will confirm the infection and then you can now use that data from the lab for your surveillance. But that's not the primary reason for telling a patient to go to the lab. Is for getting a reliable diagnosis and management option.
Okay. Thank you so much. Thank you. Thank you so much, Ma, for the response.
Thank you.
Okay, do we have more questions? And is anybody ready to share success stories? Okay, so there's a hand up here. Dr. Salisu. Okay, please go ahead. Go ahead. Your mic is muted. Please. Are you able to hear us, Salisu, Dr. Salisu? Your hand is up. Would you want to question or comment? Okay, I'm not sure. Maybe he's not aware that his hand is up. Maybe. Okay, so
Hello, good afternoon, everyone.
okay, good afternoon. Go ahead. Thank you so much. Good afternoon. We're unable to hear you. Would you want to make a contribution?
So I think at the level of NCDC also, they're trying to centralize the activities of HAI. So each
Well, I'm unable to hear you. I don't know if it's just me. Okay, would you want to type the contribution in the chat box? Because I'm unable to hear you. I don't know for other people.
Marcus internet is off.
Yeah, it's my internet. Apologies. I'm back. Sorry. Okay, I didn't get him, but I want to assume that everybody heard him. Now that I'm back, I didn't hear the last speaker, but I want to assume that every other person heard him. My network was very unstable at that time. And I don't know if there's anybody who wants to share success stories. The last question that I asked, success stories from HAI surveillance in our respective healthcare facilities. Can we share any success stories where HAI surveillance that are led to meaningful changes in patient outcomes in our healthcare facilities? Please confirm that you're able to hear me.
I know. IPC family, we're talking about standardization, we're talking about case definition. Like you said, we need stakeholders working together. There'll be like I'm sure from other do and see I get all the slides. She has on this call. She will share the slides that you can always ask questions. We can always link you up with the speaker so that the discussion can get there.
Thank you, Dr. Showande, for the contribution. Thank you so much. Okay, so like she said earlier, we're going to share the recorded section as well as the slides with you via your emails. Thank you, Dr. Fumilayo. At this point, I don't know if we have more questions, contribution or comments from anyone. Please feel free. Feel free to share, ask your questions. And I'm going to share the feedback link for the feedback form. We'd love to get your feedback on how you want us to improve the sections that we have monthly. And then if you also want the recorded section, I'm going to share the link on how you can send your email to us. Please don't drop your email in the chat box. Use the link. Use the link. Okay, I'm trying to see if there are more questions in the chat box. Okay, I can't see anyone. It's raining over here in Lagos. The network is very, very unstable. Very, very unstable. So we'll just wrap up. Yes, I'm about to share the link, please. All right, so the link is here. Please, let's use this link to send our feedback. We'd love to hear from you. Please, let's use the link to share our feedback. And then for those of us who want to get the slides and the recorded section, use the second link to share your details with us, your email address. You're going to get the recorded session as well as the slides. I'll share it with everyone. Please use the link to send your email to us so I could share this recorded section with you. And then the first link is the feedback. Thank you once again to everyone for making out time to be part of today's presentation. This time next month, last Thursday of every month, we have our monthly echo section. And this is our certificate of recognition to Dr. Olufumilola. Thank you so much, Ma, for sharing your time and expertise with us. We really
Thank you.
appreciate your invaluable contribution on this very, very important topic. I was also looking forward to people sharing their success stories for those of us who are already implementing HAI surveillance in our healthcare facilities. But maybe some other time. Thank you so much, Ma. We really, really appreciate. We really, really appreciate. Please let's say, okay, yes, some of us have already said thank you in the chat. So at this point, we'll wrap up. The links in the chat box. Well, the first one is for the feedback. Let's get your feedback, comments. And then the second one is for those who want us to send the slides and the recorded section. We'll do well to share that with you. And we look forward to having you next month, the last Thursday of next month. We'll send all the details about the topic that we're going to have. We'll share it with you via your email. Thank you once again for making our time to be here with us, and we look forward to seeing you next month. Goodbye, everyone.
Amaka, check the link. Somebody is saying the link is not the feedback.
Okay, let me reshare it. I really had a big network challenge, but let me send it again. Yeah, it's raining seriously here.
Reshare it, please.
Okay, Ma. All right, let me do that. Okay, I've resent it. So let's try this. I hope this opens.
The last one you sent was the membership form.
Yes, for those who want to send their details, yes. Then this one is the feedback form, iaco.org feedback.
Please feedback.
Yes, I have sent it again.
There are actually two links. One is feedback, the other one is most people have left.
Yes, network is so
You may need to share those links if
okay. So what I will do is that I'll share the link where I was sending the recorded section and the slides via email. So I could also attach the feedback link there so that people could, those who were unable to put their comments, can do that. All right. Thank you, everyone. So at this point, we'll draw the curtains. For those who haven't shared their email, please use the other link to give us your details, your email, your phone number, and then most especially your email address, yes, so that we can share the recorded section. So thank you everyone for being part of this section, and we look forward to having you last Thursday of next month. Thank you and goodbye.